Welcome back, everyone, to the second session on eating disorders today. I'm delighted to say hello from Dublin to you all. My name is Dr. Orla Walsh. I'm a consultant paediatrician here in Ireland, and I have a special interest in adolescent medicine and eating disorders. So I'll hand you over now to Professor McNicholas.
Thank you, Orla, and welcome back, everybody. We're delighted to offer Symposium 2 of our Eating Disorder Symposium. We were meant to be in Turkey live and be involved in a clinical training as well, but we hope you might all put it in your diary for next year, and we hope to be there in person. So without further ado, I'm going to present each of the speakers, and we will run straight into their video presentation. And at the end of that, we will have a opportunity for discussion. I'm a child psychiatrist working in the area of eating disorders, both in community child psychiatry setting, but also in a pediatric hospital, tertiary hospital setting. And our work is very much linked with that. The session for this afternoon focuses very much on how we can support parents and families of young people with eating disorders. And we're going to start off the first presentation by my senior registrar, Dr. Kristen Maunder, who is the academic senior registrar in University College Dublin. And Kristen has been involved clinically with the management of eating disorder children, but also has written quite a lot in this area. Kristen today is going to talk about the overview of carer burden in eating disorders and consider the impact of COVID. Thank you, Kristen. We will move to her video.
Okay, hello everyone. So today my talk is going to focus on exploring care burden in carers of youth with eating disorders during the COVID-19 pandemic. So I'm just going to begin by summarizing what is known about care burden in families of youth with an eating disorder. I'll then go on to comment on trends that we are beginning to see in terms of eating disorder cases and COVID-19. And then we'll then consider the additional impact on carer burden consequent to COVID-19. And finally, highlight the need for interventions aimed at supporting youth with eating disorders and their carers during COVID-19 and beyond. So just to begin with a definition of care burden. So care burden is defined as the physical, emotional, and financial toll associated with providing care. And we know that care burden associated with caring for youth with an eating disorder is substantial. The core eating disorder psychopathology, which involves an unwillingness of the child to eat, is so alien to normal parenting practice that it can throw parents off at a really early stage where they can feel completely immobilized as they watch their child refuse to eat, lose weight, and potentially become medically compromised. And we know that carers can find themselves in situations where they feel like they lack the skills or resources in order to care for their loved one with an eating disorder. And carers can feel completely overwhelmed trying to balance their new role as a carer with existing roles such as being a parent or paid employment. And we also know that if care burden is not addressed, it can lead to negative outcomes for the patient, care, and family as a whole. So worldwide, we have seen an increase in the prevalence of eating disorders during the pandemic, and also an increase in the severity of eating disorders. Particularly with children, we're seeing a more new onset incidence of eating disorder cases, as well as relapses of pre-existing cases. Also with children, we are seeing a trend where children are presenting with eating disorders at a younger age and also presenting to tertiary care centers more medically unstable during the pandemic. There's various factors that have been proposed as to why eating disorder cases, and why eating disorders have increased during the pandemic. And a few of these I've listed below and will just briefly highlight. So one being that issues of perceived self-control have been proposed to play a central role in the psychopathology of eating disorders. So a period like the pandemic where people are filled with increased uncertainty and decreased perceived sense of control could be particularly triggering for a child that is at risk of developing an eating disorder and could be contributing to this rise in cases that we're seeing. Also, there has been a huge surge in public health messaging around healthy eating, exercise, maintaining, losing weight. And this also could be intolerable for some youth that are at risk of developing an eating disorder. And unfortunately, children have been removed from their usual mood-boosting activities, such as extracurricular activities. They're not going into school. And this has led to more time where potential eating disorder cognitions could flourish, which could also be contributing to this increase in cases that we're seeing during the pandemic. So now I'm going to move on to speak a bit about unique challenges placed on carers during the pandemic. And I'll go into more detail about each one of these challenges. So given the highly contagious and transmissible nature of COVID-19, access to face-to-face eating disorder treatment has been greatly reduced during the pandemic. And there's been some carers that have expressed fears around premature discharge of their loved ones from inpatient units, while outpatient services have shifted largely from face-to-face to virtual reviews. So with their unwell child at home, carers have been tasked with the additional responsibilities of weighing their child, recording their food intake, and in some cases, taking vital signs of their children. So carers may feel completely out of their depth and overwhelmed by this additional demand further placed on them, which can further contribute to care burden. So we know that youth with an eating disorder are deemed high medical risk, and the clinical complexity of eating disorders further compounds care burden, and this has been further exacerbated during COVID-19. So patients with anorexia nervosa and bulimia nervosa are considered high medical risk due to their propensity towards electrolyte abnormalities, cardiac compromise, and bone marrow failure, leading to decreased immunity. Eating disorder patients are also at risk of nutritional deficiencies, particularly vitamin D and calcium. And studies are beginning to emerge demonstrating a correlation between vitamin D deficiency and increased susceptibility and severity of COVID-19 infection. So the medical comorbidities associated with eating disorders make this group of patients more vulnerable to COVID-19, which then places the additional stress on carers as they attempt to shield their child to minimize unnecessary potential exposure to the virus, further contributing to care burden. And there's been an increase in practical demands placed on carers overall. And if we think back to the start of the pandemic, there was this fear around food availability and a sense of food insecurity, where we went to shopping markets and there were bare shelves at times. So during this time period, there may have been a fear, especially amongst eating disorder patients, that their safe foods may not be available. And this could have placed additional strain on carers having to go to the supermarkets to find these safe foods on already bare supermarket shelves. And lack of daily structure and routine for children also allowed for more time for these eating disorder cognitions and behaviors to flourish. And carers have had to increase their vigilance, monitoring their children for compensatory behaviors such as further food restriction and increased exercise. And we also know, particularly amongst teenagers, that social media usage has increased. So teenagers are spending much more time online on social media apps. And on these apps, there's been a huge focus on weight loss and exercise and healthy eating, which could be particularly triggering to those at risk of developing an eating disorder. And also because of this increased social media usage, children are more at risk of being exposed to cyberbullying, which we know is another risk factor for the development of eating disorder psychopathology. So while carers at the best of times struggle to keep their child distracted from eating disorder cognitions and behaviors, the pandemic has created unprecedented challenges as carers are having to monitor their children even closer. So we know that psychiatric comorbidity is very common amongst eating disorder patients, and those with eating disorders are more at risk of developing depression, anxiety, and obsessive compulsive disorder. And also eating disorder patients are at a significantly higher risk of self-harm and suicide compared to children of the same age in the general population. And there was a study carried out by Boston Children's Hospital this year, where they looked at 89 youth that were attending one of their outpatient departments. And they did a survey study, and they found that over 70% of their sample of children studied noted an increase in feelings of anxiety and depression associated with the pandemic. So seeing their child's mental health further deteriorate undoubtedly impacts the psychological well-being of the carer. There was another study carried out this year in China that looked at, it was a cross-sectional study that looked at carers of youth with eating disorders and compared them to non-eating disorder carers. So those caring for children for other medical reasons, but without an eating disorder. And they found that eating disorder carers showed significantly higher levels of depression and anxiety compared to the non-eating disorder carers. So understanding and identifying key factors contributing to the increase in psychological distress amongst eating disorder patients and their carers during COVID-19 is essential to provide appropriate supports and to intervene at an early stage. So there was a review that was published in The Lancet back in 2020, and it looked at the psychological impact that quarantine had on individuals during pandemics such as SARS, H1N1, and Ebola. And what they concluded was that the psychological impact of quarantine is substantial and it's longstanding. And with many stay-at-home orders being used to contain the COVID-19 virus, carers are spending more time than usual at home, working and supervising homeschooling and trying to care for their young one with an eating disorder while they've been removed from previously pleasurable activities such as socializing with friends or other breaks such as getting out of the house for work. And we know that caring for a child with an eating disorder can contribute to a high level of conflict and dysfunction within the family environment. And express emotion is a term that we use to describe the attitudes and behaviors communicated towards the child with an eating disorder. And this includes critical comments, hostility, and emotional over-involvement. And we know that heightened express emotion is linked to poorer treatment outcomes and heightened care burden. And given the intensity of family confinement during the COVID-19 pandemic, the likelihood of high expressed emotion is very likely. Prior to the pandemic, carers may also have relied on friends or family as a source of psychosocial support, but due to advice to limit our social contacts, this unfortunately has been curtailed. So carers may feel completely imprisoned and isolated within their home, trying to balance the needs of their family, while their usual outlets to manage stress and psychological support have been curtailed due to the pandemic, further contributing to care burden. So we know that supporting carers of youth with eating disorders is extremely important, and failure to identify, acknowledge, and address care burden runs the risk of further decreasing the quality of life of carers and subsequently reducing the efficacy of care that they're able to provide. And we know that well-supported carers are more likely to provide better care, experience enhanced caregiving benefits of caregiving, and generate overall savings to our healthcare system. So in many countries, families are now a pivotal part of eating disorder treatment, and we know that family-based therapy is considered the gold standard care for youth with eating disorders. So many services have recognized the need to augment family-based therapy with parent-based support groups that focus on the educational and emotional support of carers. So here in Ireland, there's a national voluntary organization known as Bodywise that is a group that supports families and youth with eating disorders. And they developed a program known as the PLAR program, which is a support group for carers that focused on psychoeducation around eating disorders, teaching parents skills about how to manage their child with an eating disorder, and also included a supportive element where parents could speak with other parents that were going through a similar experience. And there was a mixed methods evaluation study carried out on the PLR support group that showed evidence of efficacy, with carers reporting an increased enhancement in knowledge, skills, and emotional well-being after engaging in the group. As well, clinicians also perceived carers that had participated in the group as more knowledgeable and confident, assuming parental responsibility for treatment progress. Okay. So continuing to support carers will minimize any potential risk of exposure to COVID-19 is imperative. So this means modifications of existing supportive interventions from face-to-face to online. So this may include online support groups and psychoeducational events, which could be practical and effective form of support offered to carers during the pandemic. There was a randomized control study carried out in the UK that looked at, it compared one group that was a web-based online support group for parents to traditional ad hoc support provided to parents through the organization Beat. And that just involved typing into a forum, sometimes some questions. So that was the ad hoc support group versus this very structured web-based parent support group that involves psychoeducation, skills-based training, and psychological support. So they compared those two groups, and they found that the web-based structured support group had a significantly greater positive impact on carers' levels of anxiety and depression compared to the control intervention. And we also know another benefit of online interventions is that they are accessible at any time. Given the unique aspects and restrictions placed on families during COVID-19, additional targeted components could also be added to these online support groups, such as how carers could access urgent care, and how the carer could monitor their child's physical and mental health status from home. So these are additional components that we could consider adding to online support groups for carers. So just to conclude, we know that COVID-19 poses a specific threat to the mental health of patients as well as their carers, and has placed undue strains on healthcare providers and service delivery. And the adverse impact on those caring for youth with an eating disorder seems to be increased. And further research is warranted disentangling the impact of COVID-19 on eating disorder youth and their carers. So we feel that further research that could be beneficial would include longitudinal studies examining the incidence and prevalence of youth with eating disorders following the pandemic, as well client satisfaction studies investigating perceived service provision from the perspective of not only the patient, but also the carer, so that this could potentially lead to improve delivery and flexibility of services going forward. And given the salient role families play caring for youth with eating disorders, the voice of the carer needs to be heard as clearly as the voice of the young person. And we feel that addressing care burden during COVID-19 and beyond is imperative in order to alleviate the suffering of the carer and contribute to more positive treatment outcomes amongst youth with eating disorders. Thanks very much. And if anyone has any questions.
Thank you very much. Dr. Maunder, do I pronounce it correctly? Did I pronounce your
Yes, Dr. Maunder is correct. Would you like to ask a question now, or would you like for the three other presentations to happen and hold your question until the end?
Yeah, that would be better, Dr. McNicholas. We'll wait towards the end and there'll be question and answers.
Okay,
cool.
Thank you very much.
Thank you.
Dr. Maunder, thank you very much for that presentation. And holding on to that idea of the significance of the carer burden, which in this group is even higher than in many other psychiatric illnesses, and the need during COVID to be innovative and to move to different ways of working, our next presentation is going to show an example of that. I'm delighted to present Marie Fahy. Marie is manager in speech and language therapy services for a child psychiatry group of services. And she is going to be joined by Kira Callanan, who is a clinical nurse specialist. And both of them will present on transdisciplinary, the new Maudsley online workshop, and how they have adapted that during the times of COVID. Thank you very much, and over to their video presentation.
Hi everyone, welcome to our presentation today. My name is Kira Callanan. I'm a clinical nurse specialist in Dublin North City and County Child and Adolescent Mental Health Services. I'm here today to present with a colleague of mine, Marie Fahy, Speech and Language Therapy Manager, on a joint collaboration between nursing, speech and language and family therapy on the new Maudsley method across 2 child and adolescent mental health teams during 2020 and 2021. So we'll just get started. So the new Maudsley method is a collaborative caring approach to support parents of young people with eating disorders. It was developed and evaluated by researchers at King's College University in London. And the method's all based around principles of motivational interviewing, role modeling, compassionate communication, and empathy. It's based around interpersonal components of a cognitive interpersonal maintenance model, and that caregiver responses can actually maintain eating disorder behaviors. So parents play a really important role in recognizing early signs of eating disorders and accessing treatment, supporting the young person and working with clinical teams to avoid unhelpful interpersonal reactions through accommodating a high expressed emotion. Carers therefore shoulder a significant burden, and they can feel quite disempowered from managing the illness, which contrasts with the young person and the young people, which may resist treatment, lapsing and relapsing over time. It also is compounded by socio-cognitive problems around rigidity, non-verbal communication deficits, sensitivity to threats, and social comparisons. Secondary social problems arising from abnormal eating behaviours, making recovery quite difficult. So the aim of our study was a pilot study to evaluate the efficacy of delivering 2 online new Maudsley method workshops in community CAMS. So CAMS is Child and Adolescent Mental Health Services. So the methods, we have our inclusion and exclusion criteria. So 11 parents of adolescents aged 13 to 16 years were invited to the new Maudsley online workshops. The inclusion criteria was a diagnosis of an eating disorder and attending treatment in 2 community CAMS teams. So the young people were weight restored and had attended FBT, which is family-based therapy intervention, and individual sessions. Parents were excluded if they were diagnosed with severe mental illness at baseline and if lacked internet access. So we had 2 groups, Group A and Group B. So just a little bit about the design. There was 4 parents in Group A, and they were invited to 6 weekly 2-hour workshops, and it was online, and the platform was Attend Anywhere. 2 parents, the adolescents were 13 to 16 years old with the diagnosis of anorexia and ASD Asperger traits, and all had peer relationship and social communication deficits. So then in Group B, it was across 2 CAMS teams. There were 7 parents, and this was 6 months later, and it was via WebEx platform. All young people had diagnosis of anorexia nervosa or atypical anorexia, and 6 parents of young women and 1 parent of an adolescent boy. So the assessments in Group A, we gave out the caregiver skills, the CAS scales. This was distributed to parents at baseline TO and after the intervention T1. And it measures 27 items overall. So it looks at things like bigger picture thinking, self-care, biting your tongue, insight, acceptance, emotional intelligence, and frustration tolerance. And then going on to the assessments in Group B, so the CASC, and then the teams gave the evaluation questionnaire distributed to the parents. And this looked at additional measures of caregiving skills, self-care, emotional regulation, and communication skills. So now looking at the table, the socio-demographic of the parents, so gives in both groups their ages, their education, their marital status, and then one person was African, the rest were Caucasian in Group A. And then one parent was African in Group B. And then following on again, the table, the ages, the eating disorder diagnosis, and compared to Group A and Group B, eating disorder treatment and CAMS. I think this is quite a significant number in the difference of Group A compared to Group B, 19, compared to 6 in Group B of their time of treatment or length of time of treatment in CAMS. One family had the compassion focused therapy, one young person had an inpatient stay in Group B, and then one young person had CBT. So the profile was quite different in both groups. So just to say a little bit about the intervention, it's, as I said earlier, it's all around motivational language. So we use the acronyms or little abbreviations, and we work through these throughout the groups. So the first one was ORS. So this is all around your open-ended questions. So examples were, help me understand. So this was a big change around the communication parents felt. I'm curious, using kind of who, where, how, and when, and followed up by an affirmation. Thank you for sharing that with me. Thank you for sharing how you were feeling today. And then that you are determined, you are caring, you were very thoughtful. Followed by a reflection, reflected back from the parent to the young person. And then to summarize, so checking in, have I understood you today? Is this what is happening for you right now? And then what next? The second acronym was ALVS, that's attend, label the emotion, to validate the experience, and then bring it back to how the young person can self-soothe. The final one that we used was the DEARS. So this was around maybe when things were getting a little bit trickier or maybe some resistance was happening. So developing discrepancy on the one hand, but then on the other, there's this. So being able to look at both sides of the picture, expressing empathy, that must be tough for you. And then to amplify the ambivalence, it must be frustrating when you can't join in with things with your pals or your friends, and rolling with the resistance, creating space and distraction when the resistance is really high. And offering support to support their self-efficacy throughout the whole time. To note that the parents in Group A did really, really well with the ORS, but the ALVS and the DEARS, they found that just a little bit harder to think of in the moment. And the DEARS, I think they just found was a lot more challenging to remember. So we really kind of focused on the ORS, and that worked quite well for them. Just to mention as well, the animal metaphors, and this was introduced at the start of the program. So it's all around how the parents their young person or child, and really that looking at that relationship piece. So just to mention some of the metaphors. So starting with the jellyfish. So if you were a jellyfish in the group, you might avert anger and anxiety and can exert a poisonous sting with the same uncontrolled emotions being mirrored by the young person. So quite attacking back to the young person in their way of parenting. Then the kangaroo parent. parents treat the young person with kid gloves, letting them jump into that kangaroo pouch in an effort to avoid any upset or stress. So really overprotected and really minded. Then the rhino, which is fueled by stress, exhaustion, and frustration, or one's own temperament, the rhino attempts to persuade and convince by argument and confrontation. So really, really pushy stance from the parent to the young person. And the terrier, who persistently cajoles, nags, and tries to wear out the young person. So really tries to wear them down. What the method, the new Malsey method would recommend that, we're all aiming for the dolphin approach. The adult dolphin might swim ahead, leading the way, and other times swim alongside with encouragement, showing trust and confidence. And then the Saint Bernard, who's calm and warm and nurturing and does not bark too loudly, can instill hope in change in the bigger picture thinking. So it's really trying to challenge those responses and kind of get back into that warm, empathetic stance where, like, you are the dolphin that you're nudging gently along, or the Saint Bernard, where it's calm, understanding, and warm and nurturing. And then finally, the metaphor of everyone working together in the herd of elephants. So collaborative care, linking trunks and tails to jointly care for young people. And the carer works as a team in the wider support network. Okay, so now I'm going to hand you over to my colleague, Marie Fahy, and she'll talk through the results of the adherence section. Thank you.
Thanks, Ciara. So how we defined adherence, full completion rates were 50% in both groups. And how we defined full completion was reading the worksheet manuals and at least attending 4 sessions out of the 6 in Group A, or out of the 8 sessions in Group B. So looking at our primary outcomes then, in Group A, we analysed the caregiving skills scores, the CASC, and we noted a significant increase in all caregiving skills, and that is across all domains, including bigger picture thinking, self-care, biting your tongue, insight and acceptance, emotional intelligence, and frustration tolerance. So quite a successful outcome there. Group B, similarly, in tables 3 and 4, which I'll go through with you, significant improvements were noted in personal confidence and knowledge across all caregiving skills, including self-care, emotional regulation, and communication skills. So this was quite positive because at the start of the group, the parents were reporting high levels of self-blame and self-criticism for not recognizing the signs of eating disorders sooner and not going for help sooner. So looking at table 3 then, at 2 points in time. So T0 is the start or prior to the group, and T1 is post the 8 sessions. We notice an improvement in all caregiving skills. So you'll see the increased number means increased caregiving skills. So bigger picture, biting your tongue, emotional intelligence, frustration tolerance, all scores improved. Then looking at table 4, this is the informal pre and post evaluation questionnaire that was completed by parents in Group B. So again, improvements in all areas, including personal confidence in supporting young people with eating disorders, improvements in knowledge and understanding and supporting a young person with eating disorders, self-care, avoiding getting drawn into arguments, staying calm and understanding those difficult behaviors, and celebrating those small signs of improvement and nudging their young person towards recovery. Improvement in their communication with the young person and with their family and friends. And that's stepping back and letting their young person cope with the day-to-day challenges. So externalizing the young person from the eating disorder illness. And all parents in Group B would recommend this workshop to other parents or parents. So myself and Ciara gathered parents' experiences during Group A, and this is what parents would have expressed to us. So they noted challenges in keeping their core family values, as oftentimes the eating disorder would just take over the entire family. There was a lot of issues with the siblings. All of the parents had other younger children, and they noticed that the focus became excessively on the eating disorder illness, and that sometimes the parents felt that the siblings or the younger people in the family were getting neglected, and actually sought extra support around managing that. Other parents talked about balancing the need for discipline versus talking about the challenges that the young person experienced in life and with their eating disorder. And also they spoke about their challenges catching and emphasizing the positive. They had challenges keeping communication calm around meal times because it was a very, very stressful time for them. And there was a lot of arguments or avoidant behavior. And they also talked about the questions. I mean, we would have modeled with the parents not to use why questions, which can evoke quite a defensive behavior in the young person and can appear quite blaming. So if you can imagine, if you were asked why you do anything, the first thing you try to do is justify your position. So we were trying to encourage the parents to nudge the young people towards bigger picture thinking, stepping back and not asking these direct questions, and more reflective, empathic communication, and nudging the young person towards trying out experiments and nudging them towards change. I mean, that is the overall aim of the Maudsley method. So overall, across both groups, we noticed an overall increase in caregiving skills using our measures of the caregiving skills cask and informal measures. And in group A, we did note there was quite a small group of parents, even though on the team, we offered the new Maudsley method to about 20 parents, but only 4 could make the commitment to attend. And out of that, only 2 could see the program through in its entirety. And we wondered about that as researchers, and we reflected on how the parents who are living in this area of significant socioeconomic disadvantage, how it can affect their engagement in mental health treatments, and how mental health literacy can affect your engagement with any intervention. So we came up with a solution that in future groups, we would co-design these workshops with parents just to make it more relevant to the local population, and use the parents or the carers as experts by experience. We noted the high prevalence of social communication difficulties in the young people, particularly in Group A, and we noted they would benefit from speech and language therapy support, and after the group we referred to speech and language therapy. So then our strengths, it was a transdisciplinary collaboration with nursing, speech and language and family therapy. And we each brought our own lens and our previous training and experience, which was quite a powerful thing with parents' own lived experience. The limitations then would be, there was quite a small number of parents in both groups. Only 2 finished the program in Group A and 5 in Group B. So in the future, we would like to roll this out to more CAMHS clinics in North Dublin and possibly beyond. We also reflect on perhaps in-person groups alongside online. We were restricted with COVID-19 restrictions in 2020 and early 2021. So in future, that would be a nice additional support so that parents could support other parents in a room as opposed to just online, which can affect engagement. We reflect on the need to modify the content because a lot of the acronyms can be hard for parents to remember, and the possibility of one-day workshop sessions as opposed to rolling 6 or 8 week workshops. And also there's a need to follow up with the parents with individual sessions and booster sessions just to ensure carryover of those important skills learned. So there's a complexity then in all the eating disorders presentations that were discussed in these 2 groups. High levels of comorbidity were noted, so lots of additional social communication challenges. There was bereavements in families during COVID. There was also some presentations of evolving unstable personality disorder traits. So it is really a kind of a multi kind of complexity presentation in addition to anorexia. So the timing of the group then, a kind of a challenge for us is we only received training in the new Maudsley at a particular point in time in 2020. And by then in Group A, The young people had been 19 months post-treatment in CAMS. So it's very important, since the aim of this group is to reduce carer burden, that this new Maudsley method for parents would be offered at an earlier stage alongside family-based treatment to reduce that carer burden. Also, we noted that some parents were reporting additional mental health challenges in themselves and they required additional support. In fact, one parent did not complete the program because of that. She needed extra support in adult mental health services. And our final reflection is, how best can we support parents to be engaged in these important mental health interventions so they can support the young person's recovery? Well, we think the answer is co-production, using the lived experience of carers and parents to design future workshops. So just to finish then, a special acknowledgement to our colleague, Lynn Harnedy, who's a family therapist and senior social worker, who would have facilitated the groups in Group A, and then Jennifer Kuehl, senior speech and language therapist in Group B, who gathered the data and analysed and evaluated the questionnaires, and also Justina Grabiak, social work student. So thank you very much for also joining us in this transdisciplinary collaboration. I'll take some questions now.
Thank you, Marie and Ciara, for the presentation. We'll hold questions to the end. I think what's really, really nice and exciting to see is taking an evidence-based approach like the new Maudsley, and not only translating it into clinical practice in the real world, but actually adapting it during COVID as well, and not being happy but to evaluate it and then to consider, you know, how we can progress post, whenever the post-COVID is going to be. Harriet Parsons, my next speaker, is also going to present in this area. And Harriet is the lead of training and development in our National Eating Disorder Association, Bodywise. And Harriet has been exactly in that seat, quickly modifying an evidence-based approach during the period of COVID. Over to Harriet's video now. Thank you.
Hello, my name is Harriet Parsons. I'm the Training and Development Manager with Bodywise, the Eating Disorders Association of Ireland. Thank you for asking me to speak today on how our organisation has coped and provided support services to people affected by eating disorders during the pandemic. I'm going to share with you now my presentation. Okay. So Bodywise is the Eating Disorders Association of Ireland. We're a charity and a voluntary organisation, and we provide support services, education and prevention programmes, training, professional training, and lots of other activities for people affected by eating disorders in Ireland. So that's people themselves who have an eating disorder, as well as family and friends. So life before COVID. Well, before the pandemic and the lockdown in March 2020, our organisation had several support services for people affected by eating disorders. We had a telephone helpline. We have an email support service, which is like a helpline call in an email. We have online support groups, both for adults and for teenagers. And we had face-to-face support groups in Dublin City Centre. We also have a family support programme called the PILAR programme. And our youth development officer was providing our schools programme throughout secondary schools nationally. We also are the support organisation and the support partner to the HSC National Clinical Programme for Eating Disorders in Ireland. So then in February the 29th, 2020, the first confirmed case of COVID was announced in the Republic of Ireland. And the Republic reported the first fatality on March the 11th, 2020. And on March the 12th, 2020, our government announced the closure of schools, colleges and childcare facilities. And people were asked to work from home where possible. So what happened then was that we all went home and all of our services had to go online. But generally within the population, what seemed to happen was that a perfect storm gathered. What we saw was anxiety starting to build. So people didn't know what was going to happen. People didn't understand how they were going to continue studying in school, in colleges, how people were going to continue working, how people were going to support their family. So anxiety started to build. Alongside that, there was fear and anxiety around food shortages. And we found there was a run on toilet paper in our supermarkets, and bread started to fly off the shelves. People were feeling very confined. We had a 2-kilometer radius, which we couldn't go any further. So people started to feel confined and a bit trapped within their home, within their area. As I said, there was huge changes to routines, and then being confined to the house and everybody being at home together meant that people were being around, lots of other family members that they might not have spent that much time around, or people suddenly found themselves alone, whereas before they might have interacted with people during the day, going to work, going to the office, going to college, and now they were at home and they were alone. And in terms of mental health treatment services, at best these were disrupted or paused, and at worst they were cancelled. Alongside this, we have the 24-hour media coverage of every aspect of the pandemic. And the aspect that is really relevant to people with eating disorders were all of the weight and food-related stories. So this added to the general anxiety around, what was this all about and what was going to happen. So we brought our services online. Our helpline continued to run. Our online support groups were already running. In fact, we've been running our online support groups since about 2003. And the demand on that support group really went up and up and up. There was also our email support, which also saw an increase in people using those services. And we took our family support program, the Pillar program, online. Now, this is a 4-week family program where I work with families from, different families who come together, and I work with them for 2 hours a week, 1 evening a week. And so when I took that online, what we found was people weren't hampered in attendance by location or having to leave home and have somebody come in and mind other children. So what we found were that the numbers of people attending the Pillar program absolutely skyrocketed. And in a minute, I'll show you the percentage increases on all of our services. As well as that, then all of our other work had to go online. So we started doing training sessions online, all of our talks, our conference presentations, any awareness raising talks that we did, any youth development talks, such as in 3rd level and 2nd level, they all went online. The one thing that I really found from taking the family support program online was that people missed the interaction over the cup of tea at the break. And about a year ago, in December 2020, I really thought that the families who were supporting a person with an eating disorder were feeling incredibly isolated and they needed more ongoing support. So we set up an online support group to run twice a month. And as well as that, in June 2021, we started running our first ever New Maudsley Carer Skills group online as well. So what did we hear from people with eating disorders then? We heard that people's eating disorder symptoms got worse. And you can understand this with both, the fear and the reaction to all of the major changes that were happening, as well as that 24-hour media coverage, that was on the radio, on the television, on social media. And a real trend of that was around food. So people were making sourdough starters and baking banana bread, or how were people not going to put on weight during the lockdown, and around exercise. So people were running marathons in their back garden. There was apps showing, how many kilometers you could actually walk within your 2-kilometer radius. And as well as that, the isolation led to this huge should kind of falling over society, and people felt like they should be doing more with the time they were having now at home. I should be learning a new language. I should be learning a new instrument. I should be tidying up all the garage and the shelves that I never get to because I'm too busy. And for people with eating disorders who have that tendency towards perfectionism and high achieving, and all or nothing thinking, that was really a nightmare. And that exacerbated a lot of their eating disorder symptoms. Adding into the mix, then you have the anxiety and stress, and that contributed to more emotional eating in other types of eating disorders. People reported having to be more secret about their symptoms because now they're around family members, they're not really on their own, and they have to hide things more. People reported feeling a huge loss of control over eating meals with others and receiving more criticism about their eating behaviours because now everybody is in the same house experiencing it. And all of these led to the eating disorder voice becoming stronger in the person. We also heard reports of increased compensatory exercise, and a lot of teenagers kind of tipped into an eating disorder through the exercise route, you know, going for multiple walks during the day, feeling being very regimented in what they were eating and how they were exercising. And those kinds of behaviors also exacerbated binge eating. And people really found it very difficult to manage their relationship with exercise. The control aspect was a huge part, with lots of, perceiving, feeling out of control, lots of rumination about weight and changes to usual coping mechanisms as well. All those usual social structures fell away. Alongside that, then you have everybody on Zoom and video calls. And that just brings with it a heightened awareness of how do I look to the outside world, as well as that unknown factor. And so for people who have a tendency maybe to be self-critical, that was potentially hugely triggering for them. They found that very difficult and very harmful to their recovery. As well as that increased time online added to that pressure of social comparison. And not only that, but it meant that people were being exposed to media ideals more often, as well as being exposed to ads that made those ideals seem achievable. Weight loss ads, healthy eating ads, exercise ads. And all of that adds to the comparison making, that people feel that they need to compare themselves all the time with others. As well as that, then people reported having reduced contact from clinical teams, reduced time with the professionals, and a lot more self-management of the illness by the person with the eating disorder, with this kind of lack of social support. Whoops. And for family and carers, what did they report? Again, there was a huge fear of their person being prematurely discharged from services, and a huge fear surrounding the change in how supports were being delivered. They reported, having to manage multiple needs. So needs for the person with the eating disorder and for themselves and other family members, as well as that feeling isolated and feeling like other people didn't really understand. And all of those kind of heightened unknown factors that the person with the eating disorder was vulnerable to, carers and family members were also really vulnerable to those as well. As well as that, they're trying to manage their own lives. Maybe their work had finished. Maybe they were trying to work from home and homeschool kids and work from home and deal with a person with an eating disorder. On the services then, as you have heard, and as I'm sure you have experienced yourself, people were presenting more ill. What clinicians were experiencing was an increase in referrals being more physically unwell, and every case felt urgent. So hospital admissions were increasing, CAMS referrals were increasing, and this is what we were also hearing on the services. And I think, as you can hear from other people, we're really yet to see the full impact of that. The referrals aren't slowing down, and we're certainly not seeing a slowdown on our services either. So the one clear effect in 2020 and 2021 has been the increase in demand for services. In 2020, since the lockdown, our online support groups saw 110% increase. Our helpline calls were up 48%. Our email service was up 18%, but actually that has jumped hugely in 2021. And in 2021, I think we have nearly over 3,000 emails already answered. And our attendance at our family support group was up 98%. So looking at the figures up to September 21, our online support group was again up another 40%. Our helpline was up another 73%. Our email was up another 97%. And our family support program, the Pillar program, was up another 99%. So as well as that, we did actually manage to make lots of developments during COVID. We launched a body image website called bodywisebodyimage.ie, and I would encourage you all to go there. There are webinars recorded on there around body image and social media, resources for people and for parents and for clinicians, and schools resources. We launched our primary schools program and our secondary schools initiative. And we've put together, as I mentioned earlier, this support package for families. And we've also developed a reflective journal for families to write in and keep while they're going through our support services. As well as that, you know, the training that we started doing for healthcare professionals, allied healthcare professionals and clinicians has really been popular as well. I think I counted in 2021, I've done about 25 kind of training sessions for different organizations and different healthcare groups. So I thought I would give you a little snapshot about who comes to our Pillar Family Support Program, because it might be of interest to you. In terms of gender, you know, we mostly have mums and then dads as well. And people are based in practically every county of Ireland. Most people come to the Pillar Program to support their daughter, but there are sons in there and friends and siblings as well. The age of the person, so you can see 42% were aged 13 to 15. That's the person with the eating disorder. 29% were 16 to 18, and 17% were 19 to 24. And then you can see there that blue area there is people aged 25 to 35, because we must not forget that adults also develop eating disorders and experience eating disorders. In terms of the type of eating disorder people are coming to learn about, in the main, it's anorexia, but we do see people coming about bulimia, binge eating disorder, and ARFID. In terms of where they come, where they are in their process, a lot of people are at the very beginning. It's really from the beginning. That means before they've even had a diagnosis or a referral, up to when they're being assessed, to when they're starting treatment, and then 34% there would consider themselves in the middle of treatment. In terms of the professionals that they have met so far, you can see that 43% have met a psychiatrist and a dietitian. So we would hope that that would mean that they have been seen by a multidisciplinary team. 72% have seen their GP, and that's a really good number, because we know that the GP is the gateway into the service, and the National Clinical Programme has developed guidelines for GPs in terms of what they need to do for assessment and how to refer on and how to check everything. So that's probably an indication of you know, people going to the GP as that first port of call. So what has been the most common theme then during the pandemic? I thought I would end on this to reflect on what my experience has been supporting people through the pandemic. 3 things I think I have said over and over again. When people are anxious, it's important to try and encourage them to stay in the present. My go-to phrase is, if you look after yourself in the here and now, the future will look after itself. And I think that really helps people not to worry too much about what might happen. It's really important to stick to a routine and to try, if you're supporting someone, to try and help that person to stick to their routine. And remember that if someone lapses or relapses, that's okay. It's an opportunity for learning. It's an opportunity for figuring out how to support that person better and how they can begin again. But we must remember that they never go back to the start. They're always starting from a different point. So that's all I would like to say to you today, and thank you very much for listening.
Thank you, Harriet, for an excellent presentation, and indeed thank you for your commitment through Bodywise to eating disorder youth and families and eating disorder adults, as you rightly point out. I think certainly the benefit of the cup of tea by way of informal support is so key. Even today in our presentation, the fact that most of us have been able to be present, I know you're doing it from Zoom, from home, has given that added value. And we wish we were in Turkey having Turkish coffee, have to do with Barry's Irish tea. So I'm going to go back to Turkey now, and I'm going to introduce the last presentation. It's Dr. Orla Walsh, who's going to talk about the Psychopharmacology of Eating Disorders. Dr. Orla, the floor is yours.
Thank you, Harriet, for an excellent presentation. And indeed, thank you for your commitment through Bodywise to eating disorder sympposium.
Access to services is so important, and the knowledge about the eating disorders, like you were saying with the GPs, they're the gateway to services. But of course, you also have hidden attitudinal issues which contribute to lack of help seeking, or even when you recognize you need to go for services, barriers to a willingness to go. And so my colleague and friend, Dr. Hakan Oglutu, is going to present on stigma, attitudes and knowledge gaps among carers in school, and talking very specifically about the school counsellors in Turkey. Thank you, Hakan.
Thank you so much, Professor, and thank you so much for Wahdet Görmez, our professor. And my name is Hakan, and I'm a consultant child and adolescent psychiatrist at Ankara City Hospital. Today I'll present stigma, attitudes, and knowledge gaps among carers in school counselors, and in Turkey. It's so important for us, especially for eating disorder section. And as you know, the total population of Turkey is exceeding 82 million people, and 13 million of them are young people between 15 and 24 ages, and it approximately constitutes 15% of the whole population. For this reason, Turkey is one of the most youthful countries of the Europe. And the last study showed that the prevalence rate of the eating disorders are 2.3 approximately in percentage, and with the effect of the COVID, all eating disorders are increasing nowadays. In Turkey, child and adolescent mental health services are typically in an outpatient unit and in a hospital setting mostly, and they are run by child and adolescent psychiatrists, and the number of psychiatrists are there 500 approximately. And as with the other countries, reaching to child and adolescent mental health services remains difficult in Turkey. For this reason, school counselors and school mental health services are so important for us. Yeah, you can see that, yeah. And they have a role in increasing awareness, recognition, and the support in management of eating disorders. And most of the school counselors are working in public elementary and high schools. And the number of them are more than 35,000 in Turkey. School counselors are graduated from 4-year bachelor degree of psychological counseling and guidance education program, and they have just 6 hours eating disorder training theoretically. They haven't any practical training. For this reason, they may cause lack of knowledge, and they may not recognize eating disorders very well, and they cannot refer the cases to child and adolescent mental health services. With this knowledge, we were curious about the beliefs and attitudes of school counselors, and we did a research with our colleague, Professor Dr. Fiona McNicholas, Stigma and Treatment of Eating Disorders in School Counselors in Turkey, StatSkit study. I will share the data of it. Despite the salient role of the school counselors in supporting youth, to date there is no data on this area. We aimed to investigate school counselors' attitudes, knowledge, and recognition of eating disorders. In methodology, 49 of the 50 school counselors attended to our study in Erzincan province of Turkey. We used a study-specific questionnaire which is adapted from Ireland study, and this questionnaire included one of the vignettes, and every school counselor selected one of the questionnaire which includes one vignette. They are anorexia nervosa, bulimia nervosa, binge eating disorder, type 1 diabetes, and depression. And they randomly choose one of them, and they replied their questions according to this case. They had to assign a diagnosis, predict the prognosis of the illness and response to treatment. And we also asked the gender of the case. We used a unisex name, Deniz in Turkish, and we asked Deniz's real gender. Also, we asked the illness perceptions questionnaire and some stigmatizing attitudes in this questionnaire. Now we come our results. You can see that, no, it doesn't work, okay. They accurately recognized eating disorders very well with 70%. And they recognized depression for 55%, and they know the diabetes mellitus as 25%. Yeah, we know that they are not clinicians, but they know very well to recognize them because they are mental health professionals, by the way. And they correctly attributed eating disorder cases to females, which is correct with 80%. Really good for us because eating disorders are more prone to the females. And they have better awareness, especially for anorexia nervosa with 75%. They know very well anorexia than bulimia and binge eating disorder. Yeah, and then we asked the perceived causal factors by diagnostic groups, and we see that they believed that family problems and mental attitudes of young person cause eating disorders and depression than diabetes mellitus, and other factors like overwork, emotional state, personality, diet or eating habits, chance or bad luck, poor medical care in the past, or hereditary factors are not related with causal factors, according to their assumptions. And we are curious about their knowledge. For this reason, we asked 6 questions, 2 questions per diagnosis, and their knowledge is less about this area. For anorexia nervosa, the number of correct questions is 1.6, for bulimia, 1.1, for binge eating disorder, 1.1, and in totally, the correct questions number is 2.7, which is not good, especially anorexia nervosa has a less knowledge, especially for anorexia nervosa. You can see that. It's less than the others. Yeah, we have an explanation for that because they are not real clinicians and they didn't know the differential diagnosis. For this reason, they may be less aware of exact diagnostic criteria as we expected. And we asked the treatment choices, especially the gold standard treatment, and most of the school counselors replied that the first line treatment of anorexia nervosa for adolescents is cognitive behavioral therapy, which is not true because family-based treatment is the best one for adolescents. They don't really know because in Turkey, CBT is so popular and CBT training is a part of their normal education and they recognized very well, and it's also effective for young person and adult eating disorder cases. Hence, the response of CBT is not unexpected. And even though FBT, family-based treatment, is the gold standard treatment method in Turkey, child and adolescent mental services do not use very well because it's not frequently used in Turkey. In attitudes, 60% of school counselors prefer to refer to cases to hospitals and child and adolescent psychiatrists, and they believe that treatment was more effective for eating disorders and depression compared to diabetes mellitus, and youth had less personal control over eating disorder than depression, and youth with eating disorder had fewer positive personality features compared to other diagnostic groups. These are the stigmatizations. You can see the original study from Ireland conducted by Professor Dr. Fiona McNicholas, Stigma and Treatment of Eating Disorders in Ireland, Healthcare Professionals' Knowledge and Attitudes. In this study, they asked these questions to primary health care professionals. They are GPs, general practitioners, psychiatrists, psychologists, counselors, and others like social workers. And in this study, they have really good knowledge about eating disorders. Their correct number of questions are 4.2 of 6 questions, but they less identified eating disorders to depression and diabetes because they know very well frequent disorders, but they didn't know very well eating disorders. The anorexia nervosa is the least often identified. And in some points, they stigmatized patients, eating disorder patients as well. And they viewed eating disorder patients are more chronic, they are less positive, and patients with binge eating disorder had more personal control on it. Let's summarize our study. School counselors had recognized very well eating disorders, but they have less knowledge about eating disorders, and they didn't know very well the seminal role of the families in treatment, and they are so over-reliant to hospital admission, and they are so over-optimistic about treatment efficacy of eating disorders, and these factors may limit recognition, referral, and access to treatment, and finally increases carer's burden. As a conclusion, school counselors play a seminal role in supporting youth mental health in Turkey, and this study showed that they require more theoretical and practical training in eating disorders, and if they gain eating disorder psychoeducation, they will recognize the role of parents and support them in accessing mental health services. For this reason, we need a national eating disorder program to increase accessibility, quantity, and quality of treatment services of eating disorders. Thank you so much.
Thank you very much, Hakan. And please, Hakan, stay at the podium if you wish. And I might also ask my other presenters to go back to the camera. I might ask just one question before handing it over to Professor Gomez to ask his question. Hakan, it's interesting that the teachers were able to correctly identify quite readily from the vignettes cases of eating disorders, and I suppose regrettable, even though they recognized the important role families might have by way of etiology, they were less likely to be aware of the family's role, salient role in treatment. But their higher recognition is at odds with the Irish professional data. And so I was wondering, I know the study hasn't been repeated in Turkey amongst professionals, but are we to take from the findings, even initially, that the school counsellors in Turkey, being part of that mental health service, are better trained? Or are we to lament the fact that the Irish professionals are less well trained in eating disorders?
They need to more eating disorder training, especially because they didn't know very well, and we need to train them, especially maybe treatment of them, and maybe diagnostic values, maybe accessing to mental health services. It's so important for us. They didn't know very well.
Do you think that the clinicians in Turkey would be quite knowledgeable and aware of eating disorders?
Yeah, mostly they know, but especially child and adolescent psychiatrists know that, but pediatricians and other physicians don't know very well, I think, yeah.
Right.
They didn't know very well.
Now, I was going to hand over to Professor Gomez, but actually you probably need to sit beside him in order for the video to get both of you. So, Professor Gomez, would you like to pose your question to Dr. Maunder?
Great. Thank you very much, Professor McNicholas. It was a great presentation overall. We had a chance to see the problem from lots of different perspectives of a multidisciplinary team, which we do not have, unfortunately, in our country, and hoping that Hakan will take the lead to establish one. But the awareness, I want to make a comment, if that's okay. The awareness of of eating disorders amongst non-psychiatric professionals is, I assume, is very, very low. And the problem is more so amongst dietitians. They are mainly trained to help people lose weight. So when we refer a client to, like with anorexic client, to a dietitian, I am always on the edge. I get anxious, and I go and talk to them and to see what they are really doing. So the awareness isn't that well. But in terms of the school counselors, as Hakan said, CBT is popular here, and access to CBT training is becoming more and more available. And I think their knowledge about it is coming from this mainly from CBT trainings, I assume. But I personally doubt that it is, there are more, the awareness amongst counselors here is higher than those in Ireland. As I worked in the UK for 12 years, and I was at Oxford Highfield Adolescent Unit as a registrar. Dr. Maunder is here. I assume she is registrar as well. So I was there working with Tony James. Actually, he is with us in this conference. We're hoping to see your team as well, but hopefully for the next conference. So I worked there, and I worked in Edinburgh. I've seen this perfect established services there, and now I see a perfect service, in Dublin. So I would be surprised to see that the professionals here, or even paraprofessionals, are more aware of the problem as compared to those in Ireland.
Yes. Well, I guess one of the things that we certainly could do is repeat the STED skit amongst dietitians in both Ireland and in Turkey. And it would be something that would be very interesting to do. And thank you for that. Did you have a question that you'd like to ask Kristen Maunder as well?
Sorry, any questions?
Presenter?
Sorusu olan var mı? Özellikle. I didn't have any specific questions per se, but while listening to you, I mean, it just made me think that how huge the problem is here in terms of establishment of eating disorder services. It's almost none, really. I wish we could have something in place that we could compare with yours. So as I said, Hakan is doing something in Ankara, and is taking the lead, and he's getting support from more senior consultants. But I have a question in general to ask all of you. I don't know whether you'll be able to address Professor McNicholas or other colleagues. How about those who are at risk for developing mental disorders? Would the school counselors, can they play a role in identifying those? Because almost all of them are students. They are aged between 15 or 13, 15. They are students, and they go to school, or those who develop eating disorders. So is it possible to identify it before they develop it, and what can be done in schools, whether they can play a role in just at least providing at least a simple awareness training for the teachers and for the parents?
Yes, I think it's very much what you say. The latter point there is about educating them and giving them information so that they're alert to the possibility of eating disorders and linking that in with teachers. However, eating disorders are part of kind of a general emotional dysregulation and difficulties that adolescents may have, and they may present with anxiety, depression, self-harm, or it takes a long time before you become aware that their weight is beginning to be compromised. And so I think the value of school counsellors is very much broader than eating disorders in particular. There have been in some schools and in different countries, you know, there is a nurse as part of all the school setting, and where they include weighing and heighting and vaccination programs. And if the child is sick, it's very much part of the normative evaluation of kids growing up. And that helps take away any stigma from weighing a child per se. But we are aware of unintended consequences of over-focusing on weighing. You know, a child who's overweight gets additional distress by the fact that you're going to focus on the weighing today or an exercise tolerance. And indeed, to refocus on weight in a child who is already struggling, that really should become a parental and a clinical component. So I think the role of the school counsellor is to be informed about all mental health difficulties, including abuse within families, and then for them to be able to signpost to the right services who will then offer appropriate treatment. Professor Gomez, I might ask some questions myself of the presenters, if that was okay. I was going to ask initially, maybe to Harriet, the increased number of, you know, traffic to your online support services, both from children, young people, their parents, and indeed teachers and other people who are concerned about it. The difficulty is in trying to understand, is that a real increase in eating disorders? Or is it because there has been, you know, that focus on healthy eating, which has gone both positive and negative as a result of the COVID restrictions, and the fact that maybe clinicians have been primed to eating problems. And so parents have become a lot more interested in preventing, a little bit like what Professor Gomez was saying, getting in early. And so they're just looking for reassurance, as opposed to it suggesting that there's been an increase in a specific spike in eating disorders. You know, what's your sense from the parents who've been asking the questions and the severity of the problems the young people have?
I think maybe like 9 months ago, I would have said it's probably about more awareness, heightened awareness, everybody at home together, and there was a lot of talk about it. But actually, I do think that there's been an increase properly in people developing eating disorders. A mum at a group on Tuesday said that she had been talking, her daughter's in secondary school, and she'd been talking to the school counsellor there. And she said that the counsellor that she was the 5th mother that week coming to her because their daughter had been diagnosed with an eating disorder, and she hadn't seen any eating disorders for 3 years. So I think there has been an increase. I think that with young people, there's been an increase generally in anxiety, and one of the ways we're seeing it, coming out is through eating disorders. So I mean, and I also think there's more awareness and there's more conversation, discourse generally in the population around eating disorders and that as well. But my sense is that yes, there is an increase, and yes, people are presenting more ill. I certainly am hearing younger people, 11, 10, 9, much more on pillar than I would have before. So I would say that there is an increase.
Yes. So I think the importance of continuing surveillance in this group is going to be important. In a very large electronic health record data of over 60 million people, they actually found new incidents of anorexia, in terms of people in prior 3 years that had a diagnosis versus those that were being clinically diagnosed. They found an increase of 15%. So it does suggest, that was in youth under the age of 30, it does suggest something specific. And, what would be interesting is, obviously with COVID, the relationship between COVID and mental illness is bidirectional. And whether the inflammatory response from COVID, has contributed in some ways to a particular risk when you're stressed in going down the line of eating disorders. So it will be important that we who are operating clinics bear in mind, you know, that possibility. I might ask a question to Maria and Kira, if I may, in terms of the online parenting. And there were two questions which you might like to take one each if you want. One of them was, you saw significant improvement. Now, I know the numbers are small and this is more speculative rather than statistical question, but how did it link with the children were weight restored and you offered the program? So do you have a sense of carers' burden and coping skills being improved? Is it aligned with the weight and restoration of weight and weight progress? Or, you know, any comment about that? And my second question is about if there's, in trying to teach the skills, if there's a different kind of parenting style. You mentioned the nice animals. You know, if the father is a rhinoceros and the mother is a dolphin, and they're not seeing eye to eye, and let's say you only have one parent who's on the online, you know, have you found a way where you're able to encourage shift between that animal style in either parent? And is there a time where actually the rhinoceros is a good thing to be? Maybe not always.
I might answer the second question first, if that's okay. That actually did come up a bit in the group. Unfortunately, we only had one partner present, but they would often, sometimes comment around that, like, say, dad could be a terrier and then someone else an ostrich. And I suppose maybe we discussed it through, say, one of the parents and encourage ways of bringing about kind of some change in the least kind of threatening way. And that there is always a time and place for, say, the rhino or the terrier and needs must, but to really kind of come back into that flexible mindset and empathetic parenting style of the Saint Bernard or the dolphin. Yeah, certainly that was one of the challenges that was reported, that like, say, a rhino versus the dolphin, or a terrier versus the dolphin. So it's about kind of that collaborative approach when working together with both parents and the wider team. So
yeah, thank you for that. And Maria, would you care to answer about the link with weight restoration or progress in terms of both your study and maybe speculating a little bit?
Just in terms of group A, they were quite advanced into treatment. So trying to answer your question, there were 19 months in Cam's treatment when we started New Maudsley, and coming to the end, and indeed one was discharged afterwards. So to be honest, in both those families that saw it through to the end, there was layers of complexity, a lot of psychodynamic issues, a lot of family issues in the family, and one parent was separated, but we found the main thing coming to the fore was just the high expressed emotion in the parent and how that was getting in the way of recovery in Group A. And with this program, we noticed a reduction in that. But just to say that that parent also had individual sessions with a senior social worker. So it was the combined effect of the New Maudsley, FPT, there was social work intervention, speech and language. I think it was more the multidisciplinary input there that really helped those families move towards change. And there was a lot of work put into individual families. Group B was quite a different set of parents. They were 6 months post-treatment in CAMS. And again, just very different families. Both there was 2 parents in both, there was less single families. And all of them reported that they noticed changes in their own self-care and being kinder to themselves. They were very harsh at the start and blaming of themselves. I don't know if I'm answering the question here. You're saying in relation to weight restoration, is it?
Yes, I mean, obviously you're highlighting the complexities and the confounding, additional variables that, can limit the research results. And I appreciate the study is small, but I guess it's given that they were weight restored at the beginning, and in the second group B, there was such an improvement. I was just wondering, how well did that correlate with weight gain? Do the two go hand in hand, or, do we need to focus more on the families where weight is not improving? it's static or worse?
That's a very good question. I might put that over to Kira if you have anything to add about that.
I think, absolutely that I suppose the research does suggest that high expressed emotion can cause more entrenched behaviours in that, and then that the research would suggest that even from our study with the bigger picture thinking at the end. Sorry, I'm actually gone a bit stuck, but I think it's very complex in the sense that it's hard to really pinpoint because there was so many factors within both groups. But I definitely do think that there is a link to the way being restored and the results. So yeah.
Yeah, and I mean, just my own sense is, I guess, if something's working, the motivation to change your personality style, even if one has recognized it to be slightly, unhelpful or, less reflective than you would otherwise like, the fact that weight is going on, the parent might be so nervous that they don't want to change anything. But equally, the stresses of when a child is losing weight can freeze you to the point that you can't change anything. So
yeah.
it's and I appreciate the study, won't be able to answer that because of, as Maria has said, there's so many other confounding factors there. But it's interesting.
One of the really sorry.
Jenny Langley in London, in King's College would say if something is working, just keep doing it.
Harriet, did you want to add something?
Yeah, I was just going to say, from doing the Maudsley workshops, the one thing that I think is really important and one of the real values of doing it is that the focus is not on changing the person with the eating disorder. The focus is on the parents changing themselves, and it's kind of getting them out of that circular way of thinking constantly. I need to change the person. I need to make them better. And shifting the focus onto themselves. So what can I do differently? And it's that idea of planting seeds, that by doing something differently, you're planting a seed. You don't know if it's going to take root, but you have faith that it will, but it might not. And the motivational part of it and the empowering part of it for parents is that they can do something about their situation by focusing on their own behavior. So one of the kind of truisms of it is that I cannot change anyone else's behavior. I can only change my mine. And that's helpful if the person is weight restored or if they're not weight restored, because it gives parents a breather in their head and it helps them deal with that fear that you mentioned.
I'm going to end now with one last question on a positive note. I'm aware we're running slightly over time, so please do bear with us. And this question is for Dr. Maunder. And Christian, you spoke about the high level of carer burden, which might have increased significantly for the many reasons you presented during COVID. Were there any anecdotal reports, or are you aware from your clinical practice of any positive benefits of COVID for the eating disorder group and parents looking after them?
Yes, so I'm not aware of any published studies to date commenting on this, but anecdotally from clinical experience, I have heard from some parents that they feel as though their work-related stress has decreased. This could be due to the fact that they're not having to commute to work and arrange childcare. So this could decrease their stress levels. Also, other parents have commented on the fact that the pandemic has allowed for more time for mealtime supervision of the child because they're spending more time at home. And also, we know that social comparison can be a precipitating factor and a maintaining factor in the development of eating disorders. So because we've been told to limit our social context, there has been a decrease potentially in social comparison for these children, which could also be seen as a positive in terms of eating disorder recovery.
Yes, thank you. And not that any of us would wish COVID to continue, but I guess what we are reminding ourselves is there have been some silver linings. And one of them that has been presented here today is the speed and the innovative approaches that clinicians on the ground have taken to actually adapt to the COVID restrictions and at the same time being aware of the need to continue to provide the service and to have it individually based. So the telepsychiatry works very well for some people, but a cup of tea and in-person meeting is needed for others. Professor Gomez and Professor Hakan, we are going to, unless there's any other questions from your group, we'll have to have a virtual Turkish coffee with you, and hope that we will be able to unite with you in the conference next year, perhaps.
Well, hopefully we'll be looking forward to it, to invite you as a team. It's a shame actually it didn't happen this year due to the circumstances that are known. And also I like to keep in touch in terms of some academic or clinical work share as well. We are starting up a new adolescent inpatient unit in my university in a couple of months' time. So that will be another area where I'm sure we will have anorexic girls. Inevitably they will end up there. So we would like to stay in touch. And thank you very much for this excellent talks to you all. Thanks a lot.
Thank you. Thank you very much. And thank you to all our speakers who presented today, and anybody who's still interested and who still works on a Saturday, the last day of your conference. We will be doing our last presentation then. I'm going to hand over to Dr. Walsh just to say the final goodbye.
Great. Thank you all to the speakers. They're fantastic. We learn more and more every day, and having the conversation across all disciplines is so important. And I look forward to working together with our colleagues in Turkey in the future.